All right. Hello everyone. Very good evening. And this is Dr. Pooja, your own physiology faculty. And today we are going to talk about the lung volumes and capacities. First of all, let me know if I'm audible and visible to you guys. Give me a thumbs up so that we can start. All right. Last time we have discussed about the mechanics of respiration, and today we are going to talk about the lung volumes and capacity and how do we measure them. Right. So let's start with a wonderful quote that is, a little progress each day adds up to big results, right? And we are not going to give up. We are going to continue. All right. So just let me check. Okay. It's fine on my side. So let's start with the session. First of all, understand there is an instrument with which we are going to measure this lung volume and capacities, which is called as spirometer. And the traditional spirometer was Hutchinson's spirometer, but then again, nowadays we have a lot of modified spirometers. All right. So this is known as spirometer. And the procedure over here by which we are going to measure the lung volumes and capacity is known as spirometry, right? Spirometer and spirometry, this this is one of the topic in the respiratory system. I usually say that whenever you talk in terms of systems, there will be particular topics which you have to read, है ना? हिंदी में हम बोलते हैं मत्था टेक के सोना है, right? That means you have to, there is no choice, right? You have to do these topics. Why? Because they are going to come in your prof exam, they are going to come in your vivas, they are going to come in your practicals also. So these are those must know topics. All right. So spirometer and spirometry, the traditional spirometer, it was the Hutchinson spirometer. Now in this, what happens is, first of all, there is going to be a mouthpiece which we are going to keep in the mouth. We'll ask the subject to pinch her nose or his nose and then breathe through the mouth. That means whatever air he is going to take inside the lung, he is going to take that not with the nose but with the mouth, right? Now see over here, this mouthpiece will be connected to a tube which is going to go in an inverted cylinder. All right. Now this is an inverted cylinder, and this inverted cylinder is present in the another cylinder which is going to be there. So see over here, there are two cylinders. Actually, there are three cylinders. It is shown only two over here. What will happen? There will be another cylinder inside this. So two major, if I draw it like this, so there are going to be two cylinders like this. So this is the first cylinder, and then there will be outer cylinder. The inner cylinder we cannot see, of course, and the inverted cylinder which is going to be there, right? So let's say this is the inverted cylinder which is going to come in between these two. All right. So this is the inverted cylinder which is going to come in between these two, which is going to attach with the pulley. All right. So which two cylinders we are looking over here is, first one, this one. This is the one which is inverted, right? And this is the outermost which is shown over here. There are in total three cylinder, two are vertical and one is inverted. All right. So please remember that. Now what happens is, in this I'm going to have air, but the vertical ones, where in between this inverted cylinder is known as bell, the bell is going to go, in that I'm going to have water. This is going to be filled with the water. Now why this is filled with the water? First of all, understand that this water is going to make a seal tight of this particular, for that bell. All right. In the bell I'm going to have air, and in the larger cylinder I'm having the water, right? And this bell is going to go in the small, in between the smaller cylinder and larger cylinder. Now understand, I have to separate the air of the atmosphere and whatever air is there inside that bell. How can I do that? I'm going to make a water seal, right? And in that water I'm going to dip that bell. Right? As soon as I dip that bell, what this bell will be connected to? This bell is connected with the thread and towards the lever, or we can say a writing pen. All right. So the pen is going to give me the graphical representation of whatever movement is occurring in that bell. Please remember, in between I'm going to have this pulley which is going to turn. And because of the pulley, what is going to happen? Let's see over here. When the person is going to inspire the air, that means he's going to take the air inside. Now he pitched his nose, so from where the air is going to come, he's not taking the air from the atmosphere. Now because of the mouthpiece, the air which was present in this bell, this air is going to go via a tube into his mouth, and via the mouth it is going to go in the pharynx, and then it is going to go in the trachea, right? So it is going to go in the lungs via the mouthpiece. That means he's taking that air from the bell per se. All right, now as soon as the person inspire the air volume, that means in the bell, whatever air was there, some amount of that air went into his lungs. So what will happen to the bell level? So understand, this air is going into the lung of a person, so definitely the bell is going to go down. If the bell is going to go down, what will happen to the pulley? The pulley will move. And what will happen to the pen? The pen will come upward. So if I have to show you how this looks like this. So see over here what is happening. In this scenario, what is happening? As soon as he's inspiring and expiring, this is the expiration. In the expiration, the bell is going to go up and the writing pen is going to come down. So see over here, the writing pen going up means it is inspiration. If the writing pen is coming down, that means it is the expiration. So inspiration is going to give me the upstroke and expiration is going to give me the downstroke. That is a simple funda that you should know about, right? And this is showing the tidal volume. That means you don't even know that you're respiring all the time, right? We are not doing that consciously. We know that. We have seen the regulation of respiration also. So remember that this is happening subconsciously. But if I want to blow the candles, or I want to inflate a balloon, or I want to hold the breath, can I do that? Yes, we all can do that. So, or let's say we are doing the exercise. In the exercise, I have to take more air inside, or I have to throw more air outside. So that means it is nothing but the forceful inspiration and expiration that is going to take place, isn't it? So that is also possible with this. So that we are going to measure. Now, if I ask you, if some amount of air is not coming out of the lung, will this spirometer able to measure? No. If it is not going in the bell will not move. If the bell will not move, of course, I cannot get that reading in a graphical representation. All right. For now, just remember this funda over here. We'll talk about it and we'll talk about it in detail. All right. So please remember that this is the spirometer, and with which we are going to measure the lung volume and capacities, isn't it? Now let's talk about the types of the lung volumes and capacities. First of all, if I'm talking about a single value, that is going to be volume. If I add or summate two or more volumes, that will be called as capacity. So volume will be converted into capacity if I add both of them, or two or more volumes. So see over here. First of all, there are two things. First is the static lung volumes and capacity. And second, of course, it is going to be dynamic lung volume and capacity. Now, I usually tell you that whenever we talk in terms of dynamic volume and capacity, or for that matter, anything which is dynamic, we have to consider the time. We have to take time into the consideration, right? So, whatever volume change occur, that is delta V occur per unit time. As soon as I'm going to take that, that will become a dynamic volume or capacity. Example, we'll see the example. For now, just remember the name, that is FEV1, FEV2, FEV3. These are the volumes, that is forced expiratory volume in 1 second, forced expiratory volume in 2 seconds, and forced expiratory volume in 3 seconds. All right. And if I talk about the capacity, then it will be FVC, that is forced vital capacity. Forced vital capacity, what are those? We'll see that. The ratio also we can measure. All right. Static, in which we are going to just take the change in the volume. We are not going to consider any time over here. So any volume for that matter, the tidal volume, the inspiratory reserve volume, expiratory reserve volume, the residual volume, and then your capacities such as vital capacity, total lung capacity, inspiratory capacity, expiratory capacity. In all of them, I'm not going to consider the time, and that's why they are going to come under the static lung volumes and capacities. All right, so first thing first, we have cleared with this concept. So let's move on. All right, so we are going to draw this diagram on our own, and whenever in the exam the long question is going to come, you should know this diagram. If let's say you are sleeping nicely in your bed, right, and I woke you up in the middle of the night and ask you, please draw the diagram of lung volumes and capacity, you should be able to draw this diagram. Why? Because it comes in all the type of exam. Even if you see all the entrance examination also, this is very very utmost important, right? So इस टॉपिक को मत्था टेके बिना सोना नहीं है, right? This is one of the topic in the respiratory system which you cannot miss to learn. All right, so let's talk about the volumes and capacity. I'll draw the diagram on my own. So see, first of all, if I ask the subject to inspire and expire normally without putting any extra effort, whatever normally he inspires and expires, similarly he is inspiring and expiring, right, without any extra effort. So this volume which is inspiring and expiring normally, which you are also doing right now, right? So that is known as tidal volume. So write down, what is tidal volume? Tidal volume is the amount of air. I'm going to write it as TV. That is nothing but the tidal volume. It's the amount of air coming out of the lung, coming out or going in the lung, going inside the lung, during normal, or we can say resting. Normal, resting, quiet, one and the same thing. All right, resting, let's say expiration or inspiration respectively. Expiration or inspiration respectively. All right, so the amount of air coming out or going inside the lung during the normal expiration or inspiration. All right, so that or likha hai and nahi likha, you cannot add them together. All right, so how much will be the volume? So please remember, it is usually 500 ml. It is usually 500 ml in the normal healthy adult. All right, so thank you, Ankit. Yes, future AI, if you have any question, if you have any doubt, definitely you can ask. All right, let's move on to the next volume and capacity. First is, if I ask the subject to inspire forcefully, what will happen? The graph will go much above. Whatever extra amount of air on and above the normal respiration, the extra amount of air the person has inspired, that is known as IRV. Usually it is 2 to 3 liters, right? What is IRV? I'm not including the tidal volume into it. It is the one single value, the extra value, right? So this is the extra value which the person has inspired during the forceful inspiration. So that is known as IRV. What is IRV? IRV is inspiratory reserve volume. All right, what is IRV? Usually it is 2 to 3 liters. What is it? It is the extra amount of air. Extra, I'm just writing amount like this, extra amount of air inhaled or inspired during forceful inspiration. Forceful inspiration. Please remember, it is above the tidal volume. That means we are not going to include the tidal volume into this. All right. So inspiratory reserve volume is the extra amount of air that is going to be inspired during forceful inspiration. The same thing we are going to do in the expiration also, that is known as expiratory reserve volume. Expiratory reserve volume. What is expiratory reserve volume? So please understand that when we talk in terms of expiratory reserve volume, again it is same like inspiratory, just reverse of it. That is extra amount of air. The extra amount of air. Just write expired during the forceful. Extra means, again, after tidal volume. All right, during forceful expiration. Forceful expiration. How much it is? Usually it is 1200 to 1300 ml. Please remember, I'm writing ml and liters. If I have to write this IRV into ml, then that will be 2000 to 3000 ml. Don't get confused between liter and ml. All right. So the ERV is going to be the expiratory reserve volume, that is going to be 1200 to 1300 ml. All right. Then how to show this ERV? So if I ask the subject to expire forcefully, what will happen? He'll expire like this. I'm not going to include the tidal volume. Whatever extra amount of air that he has expired, that is known as ERV. Let's write 1200 over here. Okay, so this is ERV. Now understand, there is something known as dynamic compression of airways, because of which what is going to happen is that your airways are smaller as compared to the alveoli. What I mean by that, look over here. If I talk in terms of alveoli and airway, suppose this is your airway and alveoli, right? When you start expiring the air, what will happen? The smaller, especially smaller intrathoracic airways, they are going to come under the ITP, that is the intrathoracic pressure, isn't it? The intrathoracic pressure will be applied on the airways also, and that intrathoracic pressure will be applied on the alveoli. Now what will happen? Who's having more diameter? Of course, the alveoli are larger. That means they are having more space amongst them. So what will happen? The positive ITP, relative positive ITP, they start to compress the airway, as well as they start compressing your alveoli. But who is smaller? Smaller is the airways. So what will happen after some time? If you look, the airways are going to collapse completely, but still some amount of air will be there in the alveoli. Now the door is closed, that is nothing but your smaller airways, they are completely collapsed. Now whatever amount of air is there inside this alveoli, that won't come out no matter how much force you apply. More force you apply, what will happen? More closer these airways are going to come, right? The doors are going to close earlier and earlier. So that's why when the person is having the Thank you, Ankit. When the person is having the COPD, what we say, or emphysema, we ask them to have a sleep breathing, like they expire like this. Why? Because when you have that control, what will happen? That positive pressure in the thorax will not collapse the airways quickly, so that the more air can come out of the alveoli. All right, so that is the reason we are going to ask the patient to have the pursed lip breathing. That means he cannot just expire it forcefully. He's going to have the pursed lip like that. So he's going to have or generate the you can say artificial resistance, because of which the airways are not going to collapse suddenly and more air can come out. This is known as dynamic compression of airway. because of which this is the reason to generate the residual volume. See, in the viva they are going to ask you two different questions. What are the two different questions they are going to ask? First question, how the RV is generated. So if they ask how the RV is generated, how the residual volume is generated, then your answer should be dynamic compression of airway. Now, the second question can be that why this RV is important in the body. So please remember the residual volume is important for two things. First of all, it prevents the collapse of the alveoli, right? And the second thing is you're not just having the alveoli into the lung, but also the blood capillaries, right? Blood vessels and the capillaries. So what is going to happen? The blood is continuously coming into the lung for the exchange. It is not just coming during the inspiration. So during expiration also we require to have the gas exchange between this alveoli and the pulmonary capillaries. So it maintains, the second reason is it maintains the continuous gas exchange. So what are the two significance of this, I can say the dynamic compression of airway or the residual volume? Two things are going to happen because of the residual volume. That the first thing, it prevents the alveolar collapse, right? Which is the fancy terminology for that. This is the atelectasis is the fancy terminology for the medical fancy terminology for the alveolar collapse. It is going to prevent that. And the second thing is it maintains the continuous gas exchange. Otherwise, whenever we would have just inspiring, at that time only the gas would have exchanged. We don't want that. We want a continuous gas exchange so that whatever blood is coming towards my alveolar, it should get oxygenated, isn't it? So please remember, if they ask why and how it is generated, you're going to talk about the dynamic compression of airway. What is the significance of the RV? Then you're going to talk in terms of these two things. All right. So let's move on to our residual volume. Since no matter how much force you apply, this is not going to come out. So if it is not going to come out, of course it will not go in the bell, and if it is not going in that inverted bell, definitely I'll not be able to measure. I'll not be having the graph onto it, right? So please remember, there will be no graph. That's why I'm just drawing a single line. That is nothing but the residual volume. So let's write the residual volume. What is residual volume and how much it is? It is usually 1100 to 1200 ml, right? So this is nothing but the residual volume. Now what is residual volume? Residual volume is the amount of air remained or left in the lung even after forceful expiration. Since it is not going to come out, it is going to reside in your lung no matter what. We are going to call that as residual volume. Will you be able to measure the residual volume? No. Will you be able to measure tidal volume, IRV, ERV? Yes, we can measure that with the spirometry, but we cannot measure the residual volume. So first thing, you cannot measure with the spirometer. It is going to be residual volume. Good evening, Aradhna. Good evening, Satya. So please remember, the RV is one thing that it is not going to measure. Now let's move on to the capacities. What are the capacities? The capacities are different additions, right? So I'm just removing this dynamic compression of airway. I hope you have written this already, right? So let's talk about the capacities over here. Capacities. What are the capacities? If I add the IRV and TV, IRV plus TV, that becomes IC. IC, what is it? The inspiratory capacity. Right? It's the combination of IRV plus GV. If I add the ERV plus TV, then it will be expiratory capacity. What is expiratory capacity? TV plus ERV. TV plus ERV, right? Now, if I add, let's say, if I add the ERV plus RV, then what will it be? It is going to be called as functional residual capacity, FRC. What is the FRC? It's the ERV plus RV. What is it? It is called as functional residual capacity. What do you mean by that? Why we called it as a functional residual? Because it is not per se a residual. It can, some part of it can come out, some part of it will reside inside the lungs, right? So how to define this functional residual capacity? The amount of air which is going to reside inside or remain inside the lung, left inside the lung after normal expiration. See over here, you have ended the normal expiration here, right? Once the normal expiration is done, whatever amount of air is going to reside in your lung, that is known as functional residual capacity after normal expiration. That means right now, after expiring in your lung, you're going to have the FRC. If you do pranayama and you forcefully expire there, after that, how much air will be there? After that, the RV will be there. All right. Now, if I add IRV, TV and ERV, the volume which can come out totally after the forceful inspiration followed by forceful expiration, that will be called as vital capacity. The amount of air coming out of the lung, the amount of air coming out of the lung in the normal, in the forceful expiration, which was followed by the normal inspiration, right? So normal expiration में जितनी भी हवा बाहर आती है, that is known as the vital capacity. We call it as VC. VC is very, very, very important. Why? Because on this basis, we can diagnose the restrictive lung diseases. We can diagnose the restrictive lung diseases. So please remember that. All right, let's move on. Then if I add all of them, if I add all of these values, this is known as total lung capacity. This is known as total lung capacity. Of course, everybody knows this. This is known as total lung capacity. Total lung capacity, isn't it? Now, there is one thing you must have seen. All of you must have seen this diagram. One thing I'm going to tell you extra in this, that there is something known as closing volume. Closing volume. What is it? For now, just remember that this is the end part of ERV. This is the end part of ERV. What happens is, this is known as closing volume. This is known as closing volume. End part of ERV is known as closing volume. What is it? You're going to have the lungs. Your lungs are cylindrical kya? No, your lungs are triangular. Your lungs are triangular. And because of that, what happens is, let's say this is your lung. Understand, the ITP is acting on all the alveoli that are present in the lung. But what happens is, because your lungs are triangular, that the alveoli that are present on the top will be lesser as compared to the alveoli present at the bottom, isn't it? Because at the base is always broader, base is broader, and narrow point is known as apex. Apex has lesser space, so it is going to contain only few alveoli. Now, if I ask you that the same force if you apply, and if I give you, in one scenario, if I give you one rubber band to stretch if you apply same force, and in the second scenario, if I give you 10 rubber bands and ask you to apply the same force, what will happen? Those 10 rubber bands will be stretched, but they will not be stretched that much with the same amount of force. So same is going to happen with the one alveoli and multiple alveoli. When I'm going to stretch one alveoli with the same ITP, what is going to happen? It will be stretched more, right? But in case of numerous alveoli, the same ITP will be stretching them lesser, right? So what will happen is that when I talk in terms of apical alveoli, these apical alveoli are usually larger in size, larger in the size. So write down, at the apex, I'm going to have few large alveoli. On the other hand, if I talk about the base, it is going to have numerous small alveoli. Numerous small alveoli. Now, if I ask you that if during the expiration, what will happen? During the expiration, relatively, if I talk about the first full expiration, let's say that the ITP will become positive. And if the ITP is positive, the compression force will be applied on this larger alveoli also, and a compression force will be applied on the smaller alveoli also. And what about the middle part of the lung? They are going to have the middle size of alveoli, isn't it? Intermediate. No one, of course, you know that. All right. So let's say this is the larger alveoli, this is the intermediate size alveoli, and teeny tiny alveoli at the bottom. Now what happens as the person start to expire, that the air will start coming out of all the alveoli, isn't it? But as the pressure becomes positive and positive, what will happen? That already the alveoli that are present at the bottom, or the dependent part of the lung, they're having the smaller diameter of the airway as compared to the both of them, right, on the top. So what will happen? This positive pressure will close these alveoli first. That means that positive pressure is going to close the smaller airways first, right? So as soon as, let's say, these smaller airways, they closed first. First of all, during first phase, the air is coming out of all the alveoli, but later on what happens? Only these two alveoli will be giving out the air. Why? Because the smaller alveoli, they have already collapsed their airways, not the alveoli. All right. So the dynamic compression happened at the dependent part alveoli already. Now I'm going to differentiate this with the help of different tests are there. With the spirometry, we cannot differentiate this, but there is the volume that is known as closing volume. Once this dependent part alveoli start to close, whatever amount of air is going to come after their closure, this red wala amount will be called as, which is coming from the intermediate size or the large size alveoli, that will be called as closing volume. That will be called as closing volume. And that's why I said that this is the last part of the ERP. Why? Because at that time, the smaller alveoli, they must have closed, isn't it? So please write down what is CV. CV is closing volume. I hope you understood this. The amount of air coming out of lung after the closure of alveoli in the dependent part of the lung. After the closure of dependent part of the lung. All right. So please remember that. Okay. And if I add the CV plus RV, that is the residual volume, that becomes CC. What is CC? That is nothing but the closing capacity. That becomes the closing capacity. So please remember CC and CV. CV plus RV. When I'm going to combine them together, that will be called as closing capacity. Of course, I cannot measure the RV. So I cannot measure all those capacities in which the RV is necessary. So write down the next point. What are the volumes and capacity which cannot be measured by spirometry? So spirometry cannot measure following things. First thing, we saw that RV. And what the capacities in which RV comes? That is nothing but the FRC, TLC and CC. All right. So see over here, this is the RV, right? In the FRC, I'm having the RV over here. And in the TLC also, I'm having RV over here. So I cannot measure the TLC. I cannot measure the FRC. Plus, I told you just now that what is CC? CC is nothing but CV plus RV, right? CV plus RV is nothing but CC. I cannot measure the CC also, and I cannot differentiate where exactly the small alveoli or the dependent part alveoli they start to close. So I cannot measure the CV also. All right, 2 volumes, 3 capacities. I cannot measure with this spirometry. What are the volumes? First is the RV. I cannot differentiate where my alveoli, the dependent part, smaller alveoli, they close. So I cannot measure the CV also. And whatever capacities in which these volumes are going to come, of course, that is FRC, TLC and CC. I cannot measure those capacities also with this spirometry. All right, so 5 things you have to remember. This is a patent question, will be asked by all of the you can say examiners. All right, so please remember that spirometry cannot measure all these 5 things. We have discussed this. Now if I want to know the RV, there must be some method by which I can measure the RV. No, there is no method as such that with which I can measure the RV, but yes, I can measure the FRC. And if you know the FRC once, you know the ERV, do the formula, that is the FRC. If you know the FRC for the RV, what you can do is FRC minus ERV, you'll get the RV. All right, so direct method say you cannot get the RV. So what we are going to do, we are going to do the indirect method. I'm going to use those methods which can measure the FRC, and then I'm going to measure or calculate the RV, right? So what are the methods? Just remember the name: helium dilution method, nitrogen washout method. This nitrogen washout method is very, very important. 2 things are important. You get confused in this vibe in the books. It is given differently. All right, so please remember that. Okay, Haldane effect. Okay, Yatri will discuss that later. Okay, so nitrogen washout method. Haldane effect is it is seen in the lungs, that it says that Haldane, first of all, understand it is seen in the lungs. In the lungs, you have a lot of oxygen. So it says that the unloading of the carbon dioxide, unloading means the hemoglobin will unload the carbon dioxide. It will send the carbon dioxide towards the alveoli. That thing will be enhanced. The unloading of the carbon dioxide will be enhanced due to presence of oxygen or loading of the oxygen. All right. So it will get double. Right, that means usually if the Haldane effect is not there, if the oxygen is not there, only 2 ml of carbon dioxide will be getting towards the alveoli, but it's the 4 ml of carbon dioxide which is going to go towards the alveoli, thanks to the Haldane effect, thanks to the loading of the oxygen. Right, I hope you are there and you understood this. All right, coming back to the helium dilution method, just remember the name, helium dilution method. Nitrogen washout method mein there is only one trick that you have to remember. In this, we are measuring the concentration of nitrogen and not the oxygen. Plus, what we are going to do, we are going to ask the subject to inspire forcefully. When he started to inspire forcefully, as soon as he's going to come in the middle, we are going to instruct him to take the 100% oxygen. See, we are going to put the mouthpiece. As soon as he inspired for, let's say, 1 second, we are going to turn on the 100% oxygen tab. So what is going to happen now? Because of that, what will happen? The atmospheric valve will be closed, and whatever he is inspiring is going to be the 100% oxygen. So that means half inspiration I inspired atmospheric air. Next half inspiration I have inspired the 100% oxygen. Now, why we have done that? Because please understand, as you inspired, whatever the primary air, the air that went inside first, that is going to go towards the alveoli, right? Especially the smaller alveoli and other alveoli, right? Larger alveoli. Later on, what happens is you're going to, whatever 100% oxygen is going to be there, that is, so in the small amount, it is going to go towards the alveoli, and rest of it will be there in the airways, right? As soon as you start to expire the air out, what will happen? Understand that first of all, 100% oxygen will come, right? And I told you that we are going to measure the nitrogen concentration and not the oxygen concentration. All right. So there will be 4 phases. What will happen? Let's say this is the nitrogen concentration. All right. And this is the time. As soon as he start to expire, what happens to the nitrogen concentration? First of all, the nitrogen concentration will be 0. Why? because we have given the 100% oxygen in the from the mid inspiration, we can say, right? So first of all, that 100% oxygen which was saturated in the trachea and which doesn't get exchanged in the conducting zone, that is going to come. After that, as soon as the conducting zone air is over, the next air which will get exchanged, so first phase is over and now the second phase, in that the nitrogen concentration will suddenly start to increase, right? So this is the first phase, this is the second phase. So please remember, from here to here, it is known as the anatomical dead space. Anatomical dead space, you can measure it via this. All right. Later on, what happens is, this is the third phase. This is the third phase in which from all the alveoli, the air start to come out. All right. But after some times, what is going to happen is that your smaller alveoli are going to close. And suddenly what happens is nitrogen concentration again start to increase. So please remember, that's how you know that this is the CV. This is the CV, that is the closing volume. So not only the FRC, but also you can measure the closing volume with this. All right. Residual volume you cannot per se calculate it. This is the phase 4. They have asked the question in the NEET as well as INICT that which phase in the Fowler's method it is going to measure the CV. It is going to be phase 4. All right. Please remember, we are going to measure the dead space via this. All right. I told you that the dead space, that the phase 1 and the mid of the phase 2. This is the volume which is going to be there. That is going to be, let's say this is the volume. This volume, whatever volume came out per unit time, that is will be known as the anatomical dead space. Anatomical dead space which is not going to get exchanged, right? So that can be measured with the Fowler's method. How to remember this? Please remember, as soon as you go to the anatomy department, they will take you towards the dissection hall, and in the dissection hall, the dead bodies are there, dead people are there, dead bodies are there, and as soon as you go towards the dead body, you're going to have that foul smell. You're going to get that foul smell, right? And what you do, you are going to wash it out with the nitrogen, right? And that's how you're going to remember the anatomical dead space. Anatomical dead space will be measured by the Fowler's method. How to remember? As soon as you go towards the anatomy department, there are dead bodies which are going to be anatomical dead bodies. Functionally, they are still, in use, right? To learn anatomy, right? So not functional, but anatomical dead space will be measured by the Fowler's method. You are going to get that foul smell, and for that smell, what you do, you wash them out with the nitrogen. Just remember that. Don't do that in the anatomy department. All right. So that's how we are going to remember this method. Just remember the name for the physiological dead space. That is going to be your Bohr's equation. Bohr's equation is equal to TV into the PaCO2 minus PeCO2 upon PaCO2. We'll see that in some other time. All right, not now. And we'll ask the subject to sit in the box, and we are going to measure his FRC, that is known as body plethysmography. So please remember, via these three methods we are going to measure the FRC. If they ask which is the best method, the best method is going to be body plethysmography. Nitrogen washout method for the anatomical dead space, and physiological dead space ke liye we are going to have the Bohr's equation. All right. So can you solve this question on the basis of what we have just learned? A 27-year-old man is breathing quietly. He then inhales as much as air is possible and exhales as much as he can, producing the spirogram. The graphical representation that we are going to get, spirogram, shown in the previous figure, or in the figure. What is his inspiratory capacity? So see over here, we already know what is the inspiratory capacity. This is the TV, right? So this is the TV and this is the IRV. When I'm going to combine the IRV plus TV, that will give me out the inspiratory capacity, and that's what they have asked about. So see over here, 6 minus 3, that is going to be 6 minus 3, that is 3 liters. That is nothing but, since they have given the values in the liters, so 3 liter is going to be the inspiratory capacity. That's how we are going to solve this question. If you know what is IRV, what is inspiratory capacity, what is tidal volume, you can easily solve this question. है ना, बच्चों वाला question है ये, बच्चों वाला. All right, as you have learned much of the physics, this is like bacho wala, we can say numerical for you, but you should know what is IRV, what is CV, how to calculate IC, right? For that you should know what is inspiratory capacity. That's the trick in this. All right, so let's move on to the last thing, that is nothing but your dynamic volume and capacity. How to measure the dynamic volume and capacity? What I'm going to do is, I'm going to ask the person to inspire, expire as he was doing first of all, right? Inspire normally, expire normally, inspire normally, expire normally. But then I'm going to ask him to do the forceful inspiration. As soon as he is going to do the forceful inspiration, I'm going to ask him to hold the breath for a second or so. I'm going to change some settings in the spirogram, and then I'm going to ask him, I'm going to give him the instruction beforehand, before starting the inspiration and expiration, so that it will be easier for him also, right? And then I'm going to ask him, as much air as possible, as forcefully and as quickly as possible, you have to expire the air out. So the person will expire the air out as forcefully, as much as possible. And this is the graph which is going to be generated. So this is the point at which he started expiring the air, and this is the point where he has finished it. I'm going to take a perpendicular line, imaginary line. I'm going to draw it over here, right? And this line. Usually the research says that it is going to take the 3 seconds, right? Depending on at what speed my drum is moving, I'm going to take that distance over here. For example, let's say if I'm moving the drum on which it is going to get drawn, the graph is made. If that speed is 20 mm, I'm going to calculate the 20 mm, and I'm going to again draw a perpendicular lines from them. So let's say the first 20 mm car line came over here, the second line came over here, and the third line came over there, right? And then I've drawn the perpendicular line out of them. What you can see over here is that if I draw the perpendicular line from there, so you can see during the first second, so this is the first second, this is the second second, and this is the third second, right? The research says that it takes 3 seconds for the normal healthy person to expire all the amount of air forcefully, right? So during first second, whatever amount of air the person has expired, I'm going to call that as FEV1, that is forced expiratory volume. Forced expiratory volume during first second, that is FEV1. But if I calculate the forced expiratory volume during first 2 seconds, I'm not saying second, I'm saying first 2 seconds. First 2 seconds means I'm going to include the first second, first plus second. That I'm going to call it as FEV2. And if I measure that for the 3 second, overall 3 second, that is 1 plus 2 plus 3, that I'm going to call it as FEV3. All right. What do you think? In which second, if I ask you in which second the person has expired the maximum amount of air, that is nothing but FEV1, isn't it? So please remember over here that this FEV1 percentage will be 75 to 85%, right? Distinction you can remember. Then if I talk about FEV2, since I'm including the FEV1 into that also, so the FEV2 is going to be 90 to 95%. And if I talk in terms of FEV3, it's the total amount of air, right? In this case, in some cases it can prolong also, it can go up to 4 seconds, 5 seconds, 6 seconds also. So FEV3 is usually 98 to 100%. Now the overall air he has expired, that is known as FVC, that is forced vital capacity. In this case, the FEV3 and FVC, they are similar, right? What is the difference between forced vital capacity and vital capacity? First thing is the vital capacity is static capacity, and the FVC is the dynamic one. I'm taking the time into consideration over here. Second thing is that This FVC, in that I'm going to ask the person to do the quick respiration. That means as forcefully as possible and as quickly as possible, you have to expire in the forceful vital when you are going to do the FVC, when we are going to measure the FVC, right? That is not in the case of VC. In the VC, the person can expire slowly also. We are not going to take the time into consideration. I'm just measuring how much volume came out through his mouth. That is all I'm going to look at, not the time, all right? But in the FVC, I'm going to measure the time. Now understand why this dynamic volumes and capacities are important. For that, you require to know the concept of the OLD and RLD. What is the concept of OLD and RLD? What is OLD for that matter? Obstructive lung disease, right? And this is the restrictive lung disease. So if I talk about the lung diseases, there are two types, obstructive lung disease and restrictive lung disease. So let's draw two lungs. Your lungs are triangular. Let's say this is the patient's lung, patient A, right? And let's draw the lung of patient B also. Now understand there are two lungs, but let's say in the patient A or obstructive lung disease, or let's say patient A, in that I have seen the obstruction in the airways. In the patient B, he is suffering from, let's say, fibrosis or asbestosis, silicosis, tuberculosis, whatever it is. Tuberculosis hoga, so it will be most commonly seen in the apical region of the lung. Now in the first scenario, if I ask the person to expire outside and I started measuring in how much time he is going to expire all the air, understand there is an obstruction in the way, right? So he will be able to expire all the air. Yes, all the air will come out. Why? Because at least some airway, some part of the airway is open, right? So yes, all the air will come out, but due to obstruction, it is going to take more time. All the air can come out in the obstructive lung diseases, but it is going to take more time. So if I take the FEV1 ratio, how you're going to take the FEV1 percentage or ratio? You're going to calculate the FEV1 upon FVC, right? FEV1 upon FVC into 100. That is how we calculate the percentage. What was the total volume, out of which how much amount of air came out during the first second, right? FEV1 upon FVC. Now, if I talk about the FEV1, just I'm removing this 100 over here because it will be easier for us. If I talk about during first second, can all the air come out during first second which was there in the normal healthy person? No. But if I talk about the total amount of air, will total amount of air is going to come out? Yes, the total amount of air is going to come out. Yes, very good, scavenger. It is the Tiffany-Pinelli index. Tiffany-Pinelli index. All right. So what will happen? It will take more time. So FEV1 will be reduced. FEV1 will be reduced, but can all of the air can come out? It will take more time, but yes, all the air can come out. All right. So yes, this is going to be normal. If I keep the denominator normal, but if I decrease the numerator, what will happen to the ratio? If I decrease the numerator is directly proportional to the ratio, right? So what will happen to the ratio? The overall ratio is going to decrease. The overall ratio is going to decrease. Please remember, in the old, everything decreases. In the old age, everything is decreases. So please remember, in the old, the FEV1 also decreases and FEV1 percentage also decreases. Who is the culprit? The FEV1 itself is the culprit. Since the numerator is decreasing, the percentage is going to decrease. In case of restrictive lung disease, what happens? Let's see. If I talk in terms of restrictive lung disease, so see over here, again, I'm going to take FEV1 percentage. And if I calculate that FEV1 upon FVC ratio, what will happen over here? That there is no problem in the airway, right? There is no problem in the airway. So if I ask the person to expire forcefully, what will happen during first second? Whatever amount of air usually comes normally in the normal healthy person during the first second, that much amount of air is going to come out during the first second. All right, there is no problem, absolutely no problem, right? But if I calculate all the air that came out during the 3 seconds, 4 seconds, whatever the person took for the complete expiration, remember, some area is fibrosed over here. Some area is fibrosed. So what will happen? If some area is fibrosed, so of course, it is no more elastic tissue. It's like a wood or a steel or a glass, right? Which is not going to have that recoil property. So whatever air is there, it will stay there. It will not come out, right? It is neither showing any compliance. It is not showing any recoil property, neither inflating nor deflating. So overall FVC will be reduced. Overall FVC will be reduced, right? So please remember, in this type of patient, what will happen, that FEV1 will be normal, but the FVC will reduce. All right. In the later on condition, what can happen is the FEV1 will also be slightly reduced. Okay. So first of all, let's take in the normal scenario, the initial scenario. If the numerator is normal and the denominator is decreasing, what will happen to the ratio? Denominator is always inversely proportional to the ratio. So if you decrease the denominator, what will happen to the ratio? Ratio will increase. If both are decreasing, that means FVC is also decreasing and the FEV1 is also decreasing. Numerator, denominator, both are decreasing. What will happen? The ratio will be normal. So please remember that in the OLD and RLD, that is the difference. That is the difference over here. In the OLD, what is going to take place? In the OLD, that is the obstructive lung disease, the ratio will always decrease. But if the ratio is decreasing, that cannot be RLD. Why? Because in the RLD, either the ratio is going to increase or remain normal. It will never decrease. How to remember? Just remember that in the obstructive lung disease, in the old, the FEV1 decreases, FEV1 percentage decreases. So please remember, in the old, it is going to decrease. In the RLD, it will not decrease. What is the example of OLD? Obstructive lung disease, asthma, bronchiectasis, COPD, all of that is going to come under the obstructive. Restrictive, in the restrictive, I can have parenchymal or extraparenchymal. Parenchymal such as silicosis, asbestosis, fibrosis, tuberculosis, all the interstitial lung diseases, right? And in the extraparenchymal, I can have myasthenia gravis, kyphosis, scoliosis, right? That is the forward bending of the spinal cord, lateral bending of the spinal cord. All of that come under the restrictive lung disease. So please remember, this is a very, very important topic. We have understood it nicely. I hope you understood the static volumes and capacities. I hope you understood the dynamic volumes and capacities and how this ratio is very, very important. All right. So that's how you're going to diagnose the patient on the basis of VC. The VC is going to be reduced. The static volume, if I talk about, so VC is also reduced in the restrictive lung diseases, restrictive lung diseases. So please remember, if the patient comes to you, what you're going to do? If the patient comes to you with a dyspnea and reduced, you can say, capacity, exertional dyspnea especially, that means whenever he's going to do the exertion, he's going to have the difficulty in breathing. So as soon as the patient comes to you, you're going to do the FEV1 percentage, right? If the FEV1 percentage is decreased, you're sure that it is nothing but the obstructive lung disease. If the FEV1 percentage is lesser, you are sure that it cannot be any other than the obstructive lung disease. If it is normal, the person can be healthy also, right? So you cannot just label it as RLD. You're going to check the vital capacity. Yes, if the vital capacity is normal, FEV1 percentage is also normal, vital capacity is also normal, that means the person is normal, that means healthy person, right? And if the FEV1 percentage is normal but the VC has reduced, then it is the restrictive lung disease. Restrictive lung disease, that's how you're going to differentiate between the obstructive lung disease, normal, and restrictive lung disease. So that is all from today's lecture. I hope you enjoyed this and you understood everything. If you have any doubt, you can ask me, right? You can ask me anytime on the Instagram group, on the Telegram group, on the CB official group, right? I'm everywhere, all right? Don't ask me on the Facebook. I don't usually open the Facebook, right? So whenever you have doubt in any topic, I'm going to be there. All right, it might take some 1 or 2 days, right, because there are many queries, but definitely I'm going to solve. And if you have any special topics to take care of, or you want me to discuss special topic, so please give me those topics also. So that is all for today's lecture. See you in the next one. So if you have any topic, let me know in the groups. All right, so thank you very much. Bye bye, take care, good day.